Much
Thank
being
you.
with us.
Thank you. It's always a pleasure to talk to people. This is the first time I do it on this virtual platform. I log on to Facebook maybe twice a year and I update my status periodically. But in any event, I am honored to be able to participate in this process during these difficult times. And these challenging times present opportunities for us to learn, potentially to see patients in a different way remotely, to take care of patients remotely, and now to communicate with the community remotely. The community obviously can be expanded when we're talking virtually, and it's not limited to the people who can simply are able to attend a lecture at a particular facility. They can do it from home without having to live under these circumstances. Today, I will be talking about strokes, and this is a process that we do yearly at Riverside. We try to engage the community and educate them about matters pertaining to stroke care, stroke prevention, and the various aspects of strokes. Given the limited nature of the virtual talk, uh, I have limited my discussion to some background education on stroke. And obviously, we're open to discussion from the audience, the participants, with regard to any specific questions they might have. So I'll begin by talking about stroke epidemiology. The latest data we have is from 2018. And basically, it is one of the leading causes of death in this country. And certainly, it's the leading cause of morbidity, where people are sick and costly to the families and to the healthcare system. Someone has a stroke every 40 seconds. Somebody dies from a stroke every 4 minutes. And we have seen a decline, but not enough. Unfortunately, what we're also seeing is an increase in the number of strokes that's affecting people under the age of 50 and under the age of 45. And there may be multiple factors involved in that. There are unfortunately also ethnic uh, differences, whether it's among African Americans or Hispanics. We see trends that are not very helpful. The risk factors are typical of any other vascular disease. A stroke is a vascular disorder whereby a person occludes a blood vessel. And the typical risk factors are smoking, physical inactivity, poor nutrition, obesity, cholesterol, blood pressure, diabetes, and age. Again, as noted earlier, that age is becoming younger and younger. We have different types of strokes. A blood clot can break loose and travel up to the brain into an artery and occlude it, as you see in the picture on the right. And in the picture on the left, the blood vessel may burst and we get a hemorrhage. So we have hemorrhagic strokes and non-hemorrhagic strokes. A TIA that people hear about a lot is nothing but a stroke that happens not to leave any permanent deficit or damage. So the clot that occurred over here, blocking the artery, was very temporary in blocking the artery. So the symptoms occurred, and then when the clot dissolved and broke loose, the blood flow resumed and the symptoms went away. We like to think that it's a focal deficit that does not leave any permanent damage, but we know from MRI data that about 30 to 40% of patients will show changes that are indicative of some damage to the brain. And this is why we look at TIAs just as seriously as we look at strokes, because they portend the potential development of future strokes in 10 to 20% of patients within 3 months. And that is the critical component that we have to try to prevent. Whether it is a TIA or a stroke that has permanent deficit, there is a high chance of developing another event in the near future. How do we make a diagnosis of stroke? It's the story. A person tells you, I have lost my balance suddenly, I've lost function in my arm suddenly, I lost speech suddenly. And these symptoms have to fit in a particular distribution. Every blood vessel that goes to the brain goes to a specific area of the brain. It goes to an area that controls the arm and the face, or an area that controls the eye movements. And depending on the collection of the symptoms, we are then able to determine which blood vessel may be involved. If somebody comes in with right ear numbness and left toe tingling, probably that's not a singular blood vessel because the areas that are involved in that in the brain are far apart. So we, based on those symptoms, we really don't have any specific test that tells us indeed it is a stroke. And very early on in a stroke, the typical imaging techniques like a CAT scan that we use are negative. Now we have other modalities that we can use, but because we are trying to reach a diagnosis very quickly, we rely heavily on the clinical symptoms. The other diagnostic modalities can take more time to do, and therefore we want to try to establish very promptly whether a person has any problems in their brain other than possibly a stroke, let's say a brain tumor or a hemorrhage, in order to begin treatment very quickly. So we do typically a CAT scan without contrast to determine if there is blood or not. Ischemia means loss of blood flow, hemorrhage means bleeding. So we want to determine, is it a blood clot that interrupted the blood flow to a part of the brain, or is it a hemorrhage? The role of functional imaging may become more useful at later times, but in the beginning, first few minutes, it's a plain old CAT scan and the clinical history that makes the determination. So at that moment, we are asking three questions. What happened? How did it happen? And why did it happen? The story tells us what happened. I woke up with this deficit, or I was eating and suddenly I got weak on one side, and so on and so forth. We get the CAT scan, we document presence or absence of a hemorrhage. At a later time, we might be able to get an MRI and it shows the extent of the damage. But then we need to prevent another event. So how did the stroke happen? This is where we look at different mechanisms of strokes, which we will talk about in a second. And then the last question is why it happened. And these are the risk factors that we alluded to earlier. Ultimately, knowing how a stroke happened allows us to choose the right medication to prevent that stroke from happening again. Knowing why the stroke happened allows us to modify these risk factors. So now we try to treat patients very quickly. We want to be able to treat patients with an acute stroke within the first 3 hours to 4.5 hours. So we use last time known normal. Somebody tells us, I talked to my mother at 4 o'clock this afternoon, and then at 5:30 she was found on the floor not moving. So we assume that the stroke events began at 4 p.m. and we have about a 4.5 hour window where we can administer some of the medications. We want to make sure that patients don't have any hemorrhage, and we're not really sure we want to include patients with a very large deficit. This is something called the NIH stroke scale. As far as risk modification is concerned, we cannot change certain things: age, race, gender, family history. Men are more likely to get strokes, age over 50 is more common, and then obviously family history. But these are the modifiable risk factors: hypertension, diabetes, knowing that they've had prior strokes if they're taking the appropriate therapy to prevent it, cardiac disease, open valves. PFO is a connection between the heart cavities that allows clots to go from one side to another and then go to the brain, causing a stroke. Irregular heartbeat or atrial fibrillation, high cholesterol. There are certain conditions in younger people that are called hypercoagulable states. I just recently diagnosed a lady who is 78, 79 with a hypercoagulable condition. And when we made that diagnosis, we are now able to give her the right treatment to prevent that stroke in the future. We didn't simply assume just because she is 80. Obesity, alcohol, too much alcohol, too little alcohol may be okay. like a small glass of wine, not the big glass where you can put the whole bottle, just the tiny glass, 6 ounces, that may actually help. But too much alcohol can cause blood disorders, clotting disorders. Cocaine is a very common cause of drugs among young people. Oral contraceptives, particularly if somebody has a history of migraines. So, when I see young ladies who have complex migraines, that means migraines with neurological symptoms, blurred vision, numbness, tingling, and they are on contraceptives and they smoke, that's a recipe for disaster. Certain autoimmune conditions like lupus, elevation of a certain chemical called homocysteine, and sleep apnea, which is becoming more and more recognized. Now, you can see a lot of these are somewhat interrelated, having obesity, high cholesterol, diabetes, hypertension, and sleep apnea all go together. And they can potentially be managed by modifying one risk factor, which is the weight. Excuse me, my slides are slightly out of order, but I'm missing a slide. It's okay. Um, this is the modern technology. So I want to go back a slide and discuss how strokes happen. We can get atrial fibrillation that breaks the blood clot loose from the heart. And those types of strokes are prevented by using a medication called Eliquis, Xarelto, or Coumadin. You can have a hole in the heart that makes a clot happen and break loose going to the brain. That's from the heart. We call that an embolism from the heart, and typically these are treated with blood thinning medication. Another area where strokes come from are blockages in the carotid arteries or the vertebral arteries. And these blockages, particularly the carotid arteries, we are able to open them up and do surgery to keep the blood vessel patent so that flow is smooth. Usually, if there is a 60% blockage or more, we operate to try to prevent further strokes. Some people will operate on blockages even if the person has not had a stroke. For example, you could have a blockage that reaches up to 90%. And if it gets to that point, the likelihood of having stroke is so high that we actually go and do the surgery before a stroke has happened. So that's another mechanism of stroke. And then the arteries deep in the brain can become narrowed and blocked and filled with cholesterol plaque that they occlude upon themselves. Those types of strokes are typically smaller strokes. If it is a stroke from the carotid or vertebral arteries in the back of the neck or deep in the brain, then we typically try to use uh, blood thinning medication like aspirin or Plavix. They inhibit components of the blood called the platelets from aggregating with each other. Whereas the heart, we try to prevent clots from forming by inhibiting the clotting mechanism using Coumadin or similar medication. So it is important to figure out how the stroke happened, but the more important aspect down the road is to figure out why the stroke happened and modify these risk factors. So then, after a stroke has happened and the person is left with a certain deficit, there is really an infinite amount of recovery that can happen. That's not necessarily 100%, but there can continue to be recovery in rehabilitation, which is regaining functionalities. That doesn't mean I'm up and running around and climbing mountains, but I could be more independent. What predicts recovery is the health of the individual, the age of the individual, the severity of the deficit, and how much recovery occurs in those first 24 to 48 hours. What prevents recovery are other medical problems, uncontrolled diabetes, infection, depression, um, and certainly a person's motivation for recovery. Which brings us to a point that the majority of patients who have strokes, however mild they may be, often develop depression, which can hamper the recovery. So we often prescribe antidepressant for such patients. Uh, then How much rehab to do? Well, it's basically as long as the individual continues to demonstrate benefit, we continue to give them support with rehabilitation. We can do some Botox sometimes for spasticity and increase muscle tone, ultimately trying to improve functionality. So the way I look at strokes is not an eventuality that does not have any long-term benefit from management. We can manage every aspect of a person who's had a stroke to make them have an improved quality of life. More importantly, we need to prevent the stroke. More importantly, if there is a stroke, we need to show up in the hospital and be fast. Be fast stands for the following. Fast is the old terminology that we had to remember. Face, if there is a facial asymmetry, arm, if there is an arm weakness, S for speech, and time for when the stroke happened. We have added be fast to talk about balance and eyes, loss of vision in one eye, double vision. So we want to be fast, recognize the symptoms of stroke very quickly, and document the time, call 911, and get the patient to a facility where they can be given the blood clot busting medication. And I think this is the lecture. So if you have any questions, please don't hesitate and participate in the question and answer session.
So, Dr. Sweden, there looks like there's a lot of chat on the side. So we should start with that first. No? Okay. There's some comments. No, okay. Okay. So, Dr. Sweden, can prolonged high blood pressure affect your chance of having a stroke?
Absolutely.
Okay.
So,
Uncontrolled.
unfortunately, the American Heart Association continues to lower that blood pressure guideline. So, if you
Mhm.
thought 130 over 80 was okay, it's not. It's less than 120, less than 80. So, we want to keep dropping that blood pressure as best as we can. And the best way to do this, whether it's medication, but mostly weight control and exercise.
Okay. Good to know. All right. And can having years of migraines impact your eventual chances of having strokes?
Under the circumstances I mentioned, in people who are taking hormonal therapy in women, or if they are smokers. So,
Okay.
if you don't smoke and you don't take oral contraceptives, then the likelihood is not that much higher than the average population.
Good to know. Thank you so much. Okay. And so another question that came up is um, having treatment for stroke different if you don't arrive within the set time. How is the treatment different when you don't arrive to the hospital in the set time of the onset of symptoms?
So, we have several aspects that we can participate in right now. If we are in the first 4.5 hours, we can give the blood clot busting medication. In the first 6 to 12 hours, if there is a clot that we can visibly see on the studies that we do, then we can go and retrieve that clot. And there are tests that we do that tells us how much viable tissue has remained in that part of the brain that has been blocked. If there is significant viable tissue, then we try uh, more aggressively to remove the clot. So there are things that can still be done. But beyond that, we also want to figure out very quickly why the person had the stroke so we can implement those measures that we talked about. So even though it's not in the first 3 or 4 hours, don't hold back on coming to the hospital because you think it's too late. No, come sooner.
Okay. Thank you so much for that. Um, so we talked about AFib um, a lot, but how is AFib connected to your stroke risk?
Because with atrial fibrillation, the blood pools in the heart as opposed to being squeezed out with regularity. The atrium is fibrillating, essentially doing this. So when the blood pools, it clots. And when there is another squeeze from the heart, one of those clots may break loose. So that's how it's connected.
Okay, got it. Thank you. Um, and once someone has had a stroke, what can they do? So we talked a lot about that, that they can reduce their chances. And really, the main thing is losing weight, right?
That's
Keeping your weight down. One of the main
one
things.
of the main things because it can manage several aspects at the same time, whether
Okay.
it's diabetes, blood pressure control, or sleep apnea. So
Right.
that's actually big bang for your bucks.
Right. And I am concerned about the strokes occurring on with the younger age, the 40 and 50-year-olds. And Can you touch on that a little bit more? Why, in your practice, why are you seeing trends in that age getting lower and lower?
Well, uh, possibly in some cases, what I'm seeing less access to preventative healthcare. So people go on not knowing that they have high blood pressure because they think they are young and they are invincible.
Mhm.
So they're having strokes. Potentially a return of smoking. Unfortunately, I'm seeing that among young people. So that's a problem. And then changing demographics. There are more strokes among Hispanics and African Americans. Uh, Now, we do have a question online whether the symptoms are less visible for a minor stroke versus a major stroke. Absolutely. Now, the term minor is relative. I'll give you an example. We use the NIH stroke scale. The NIH stroke scale gives you a point for variety of deficits, 2 points if the deficit is moderate, 3 points if the deficit is severe. So a mild stroke is considered 1 to 4. Zero are no symptoms. What if you lose your speech and are unable to communicate? That only gives you 1 point. Now, if I'm unable to talk, I have lost my job. So to me, that's not a minor stroke. But in terms of the size, it's a very small stroke. It just happens to be the location. Somebody who gets a stroke in a very small part of the brain where they can no longer swallow, they can be devastated. So the symptoms can be less visible at times, but in general, the symptoms are relative to the location of the stroke rather than the size of the stroke.
Well, Dr. Soueidan, we can't thank you enough. You are always so helpful to
Thank
us,
you.
and we really appreciate and we know that you're an amazing doctor.
I will do a better time fixing my slides, but now that I know how this thing looks.
Well, unfortunately, it wasn't your problem. I think we did it for you. So we're
That's all
sorry
right.
about that.
But I should learn stuff myself as well.
No.
I take
Well,
responsibility.
we all learned a lot. We all learned
Thank
a
you
lot.
very much.
Thank you so much. We really appreciate you being
And
here
thank you all
this
for
evening.
attending. And I hope you learned something.
We all learned a lot from you. Thank you.